Hello, my name is Larry Williams and welcome to Health Matters. Today's program may not be suitable for all ages. We're going to be dealing with a topic that is very personal. However, it's a topic that needs to be discussed and information disseminated to everyone. Whether it is your father, brother, son, uncle, your husband, or your partner, or any man in your life who is very important to you, this program is for you. Last year in the fall, I was scheduled to have my yearly physical. I almost decided not to go, since I felt I was in the best shape of my entire life. I was working out every day, my weight was in pretty good shape, I was good to go. I made an appointment anyway. I had my blood work completed. In a few days I came back for our actual physical exam. My doctor came back with some disturbing news. All of a sudden, my PSA count had jumped from 2.2 the year before to 3.9. He was concerned. The danger zone, or the questioning zone, was 4.0, he said. He said I could wait and have it checked out in 6 months, or I could go to a urologist and have a consultation. Being that I was an adopted child, and not knowing my family medical history, my doctor thought it was wise to seek further consultation. It unnerved me a bit, but again I felt I was okay. I had no symptoms. I made an appointment with a urologist and he reviewed my results. He conducted a rectal exam and he felt it was necessary to do a biopsy. He said that one side was a little different in feeling and he thought we better go ahead and get the biopsy done. The worst call I've ever had in my life came in October of last year, when my doctor told me the biopsy results that 30% of my prostate was cancerous, and on a scale of 10, the aggressiveness of this type of cancer that I had was a 7. To say that I was depressed is an understatement. I cried. I could not sleep. I felt like I was starring in a bad Lifetime movie and I didn't want to star in that movie at all. I had no symptoms, no pain, no nothing. But the level of aggressiveness of the tumor was a concern. Had it spread? The more I read about this type of cancer and what I had, the more depressed I was. Options were presented to me and what I could do next. I opted for surgery, and on December 24th, 2012, yes, December 24th, 2012, I had my prostate removed. One lymph node had 1% indication of other cancer. It was removed. I did not need any radiation or chemotherapy. I am on hormone therapy right now and will be for the near future. It has almost been a year and my PSA count remains low. I'm very thankful. I'm very blessed. Today's program is about prostate cancer and my special guest is Ruth VanGerpen, who is the clinical nurse specialist in oncology at Bryan Health. Thanks, Ruth, for being here today.
Thank you for inviting me. It's my pleasure.
It's great to have you here. Maybe you can just tell our audience a little bit about your career and about yourself.
Well, as you indicated, I am a clinical nurse specialist. My specialty is that of oncology. And I have been, believe it or not, that's been my focus for about 28 years of my 37 years in nursing. Mm-hmm. And I have been at Bryan Health, working at Bryan Medical Center for basically all of my career.
Okay. Well, that's a nice, long, and distinguished career. You must have started when you were 9.
Oh, you're very sweet. Thank you.
Okay. Well, this is a very serious topic and something that's very personal to me and something that I want to share with all the people that watch Channel 10. What is the prostate and what are its functions?
Well, the prostate is a gland. It's about the size of a walnut, so it is relatively small. Sits at the base of the bladder. The urethra runs through it. And its primary function is, what it does is it helps to nourish, produces some of the fluid in which the sperm cells are protected and actually then placed in with the semen. Mm-hmm. So that's its job.
Okay. How common is prostate cancer?
Prostate cancer is the most common cancer that is diagnosed in men in the United States. It's estimated, for instance, in this year, in 2013, that over 200,000 men will be diagnosed with this disease. And if you look at it from what's my risk? It's estimated that about 1 out of every 6 men will be diagnosed with prostate cancer.
Okay. Who's at higher risk for prostate cancer?
You know, there are several risk factors, and you kind of alluded to one of those when you were sharing your story. But the biggest risk factor, the strongest one, is that of the individual's age. We know that the vast majority, it's about 2/3 of all prostate cancers are diagnosed in men over the age of 65. It's unusual for men younger than 40 to be diagnosed with prostate cancer. Doesn't mean it can't happen, but it is rare. But beginning at about the age of 50, the incidence, the risk really dramatically increases. Another risk factor is that of race. And what we also know is that prostate cancer occurs more often in black men than it does in men of any other race. I wish I could tell you I knew the answer why, and we really don't truly understand that, but we do know that a person's ethnicity does make a difference in including their race. The other risk factor that you commented about was the fact that you don't know your family history. And family history is a risk factor. It is important for all men to know their family history, especially if they have a father, a son, or a grandfather that's been diagnosed with prostate cancer. It's also important for them to know the age at which their family member has been diagnosed. If the person is younger, say in their 50s versus somebody in their 70s or 80s, that can make a difference on the person's risk as well.
Okay, so I'm over 50, I'm African American, black. I was at risk.
Yes, you are.
Okay.
And you were, yes.
And I was at risk there. One other thing I would share, is having told my story to other folks, I found that there were 2 other African American men in the community that I know that had surgery within 3 or 4 months after I had surgery. And we were all in the 50, 60 age bracket. You know, I didn't have any symptoms. I didn't feel a thing. I felt great. I was working out every day. I had lost weight. I had no back pain, no nothing. What are some of the symptoms? How will anyone know?
You know, you're typical of an early cancer, and it's not just with prostate cancer. Early cancer, when they are small, don't typically cause symptoms, and that is very true with prostate cancer. The only symptom, if you want to call it a symptom, it's more of a sign, and that is that there's a change in the person's PSA, or their prostate-specific antigen. It's a protein that is secreted by prostate cells, whether they are normal or whether they are cancerous. And it's that increase in a person's PSA that may be the first sign that there is some change happening. Now, an increase in PSA, I'm sure as your doctor shared with you, is that doesn't always mean it's cancer. It can be due to an infection. It can be due to inflammation. It can also be due to enlargement of the prostate gland, more tissue, more PSA being produced. But as prostate cancer spreads, as it leaves the prostate gland and maybe spreads to lymph nodes that are nearby, or more concerning, when it spreads to the bone, which is usually the first place that it will spread to, that's when we'll start seeing the symptoms related to pain, such as back pain. As the prostate gland may get larger, they may have trouble urinating, whether it's getting up at night more often, which may or may not be a sign of cancer, but it shows there's something going on. Or blood in the urine, blood in the semen, those things as well could possibly be signs as well of prostate cancer.
One of the things, I've heard of some controversy over the PSA count and test, and not so much on the elevated level of your PSA, but maybe you can just talk a little bit about the science and what it kind of indicates to us. You know,
you're right. There has been a lot of controversy and a lot of debate over the last year and a half about PSA screening. Who should be screened and when is it appropriate? And one of the things that is lacking, which really has spurred or sparked the debate, is that the studies that have been done have really not been able to show that if we screen and we find a prostate cancer early, that it makes a difference in how long the man lives, how long their survival is. What we do know is that PSA screening on an individual basis is important. And it may not be for everybody to start at the age of 50. For some, it may be recommended to start at the age of 55. For men who are Black, it's recommended to start earlier, such as the age of 45. So the current recommendations from the professional organizations are, number one, is that have a discussion with your physician, your provider, about screening. Is it right for me? The concern also is the fact that if we find prostate cancers, not all of them are going to cause or result in a shortened lifetime for that person. Some of them are very, very slow growing. They're not aggressive at all and would not have caused a threat had it ever not been diagnosed. But right now we don't always know who is and who isn't going to be at that high risk. So bottom line, have that conversation and say, should I, when should I get started, and how often should I have it done?
And my physician, my primary care physician, we had that conversation. And the factors that we've talked about, I was over 50, I'm African American, Black, and at the same time, I didn't know my medical history. And still don't. I mean, I have some general ideas who my parents were, but I didn't have any specific information. So he did give me some options, but he strongly recommended that I go ahead and consult a urologist.
And I think it was exactly what should have been done, is that there was that conversation. And fortunately, your physician brought it up. For men, if their physician doesn't, it doesn't mean it's not important. It just means, among with everything else, it just may have gotten missed. So if they don't ask you, each person needs to ask their doctor.
You need to take control of your own medical care.
Absolutely,
and ask the questions. A biopsy is needed basically to actually determine whether or not there is cancerous growth, correct?
That is correct. And that's true with any type of cancer. You cannot say just because your PSA is starting to rise that means you have cancer, and you can't be told, well, we know you have prostate cancer, your PSA is going up. You have to have biopsy. You have to have a piece of tissue, whether it's from the prostate gland or other areas in the body, that needs to be examined by a pathologist that is able to identify that it is cancerous.
I had a Gleason Scale, a score of about 7, and I was told that was fairly aggressive but fairly common also. What does the Gleason Scale, what's that all about?
What is it about? It is one thing. It's a number that is assigned by the pathologist when they examine the biopsy. Or they will also do it if somebody has had their prostate gland removed. They will also examine it and provide a Gleason score at that time as well. What it does is it really does show the aggressiveness, how fast that prostate cancer is growing. And the number that is given is between 2 and 10. They will assign 2 numbers. Oftentimes what you will see if you get a report is it may say, in your case, it would have been a 3 + 4 or a 4 + 3.
It's 3 + 4.
3 + 4.
Right.
The first number is the most common appearance of the cancer cells. In other words, showing how much it has changed from a normal cell. The second number is the second most common appearing. And there are very strict criteria that pathologist uses to assign a number. So your most common was 3, your second most common appearance of the cancer cells was 4, giving you a score of 7. Your most aggressive ones are considered to be a Gleason score of 8 to 10. So a 7, I would tell you, is one of the most common numbers that we see. But it also is kind of on the upper side of your moderate range. It is not. And when you get down to a 5 or a 6, even a 6 is sometimes considered to be less aggressive even than a 7. So every man who has ever been diagnosed with prostate cancer should know their Gleason score, because it does impact prognosis. It impacts future discussions with your physician as far as, what does this mean for me and how often do we need to continue to watch?
Ruth, let's talk a little bit about treatment for prostate cancer. Early stages, and then we'll move to later stages.
Okay. Early stages, and let me start by defining what an early stage is. People talk a lot about the stage of cancer, and it is important because it helps us know treatment options and what we can expect from the disease. But early stage in prostate cancer means that the cancer was confined to the prostate gland. There wasn't any evidence from examination after the prostate at the time of diagnosis. Or if the person has opted to have it surgically removed like you did, that there was no evidence that it had gone to lymph nodes or outside of the prostate gland itself. So for early stages with prostate cancer, surgery is an option, such as what you chose, the removal of the prostate gland, radiation therapy, cryosurgery, which is freezing of the prostate, hormone therapy may also play a role, even in early stage, but there needs to be some added treatment. Chemotherapy is more for late stage, and we'll talk about that then in a little bit, or what was called active surveillance. Sometimes you'll hear the terminology watchful waiting being used as well. But for men who have a slower growing cancer, prostate cancer, this would be a Gleason, for instance, of a 6 or below, is that monitoring, or what is called active surveillance, is sometimes recommended. And what that means is that the gentleman, the man himself, would be having PSA blood tests and digital rectal exams more frequently, such as every 3 to 6 months, to keep an eye on it to see if there has been any change in that PSA, any increase at all. For men who have kind of more the intermediate risk, Gleason score, in some cases even a 6 or a 7, or higher, is then we look at other options such as surgery, the removal of the prostate gland itself. And there are different approaches in which that can be done, but all again achieve the same goal. Radiation therapy is another type of treatment that actually has shown to be, through a lot of studies over the years, to be as effective as surgery. There may be reasons why a man may choose to do surgery over radiation therapy or vice versa. Oftentimes it has to do with either some of the side effects that can occur. It may be also due to the fact that their health may not be good enough to tolerate a major surgery, and radiation therapy would provide an equal option for them to consider. Radiation can be delivered in 2 different ways when we talk about it for prostate cancer. The first is it is delivered by a machine that precisely can target the prostate gland itself and give high dose X-rays, which is really what radiation is, that will basically destroy the prostate gland. The other option is through the use of seeds. And seeds, the radiation seeds are, a seed is about the size of a grain of rice, so exceedingly small. And what is done is, in a surgical procedure, there are a number of seeds, and these are radioactive seeds that are directly placed into the prostate gland. And they serve the same function, the same goal of destroying the prostate gland. And that's a conversation, again, with a specific radiation oncologist to determine what's going to be the best option for you. A urologist would also be able to help provide that direction. Now, a third option, and one that is probably one of the newer ones, is that of freezing the prostate gland, or cryosurgery. And that is something that also can be used to treat early stage prostate cancer. So it's something that it's important to understand what all the treatment options are, and then for you, along with the urologist, really to decide what's going to be the right option for you, for your health, as well as for your overall life goals.
I'd like to share with our audience that I opted for the Da Vinci method of surgery, which it's done robotically.
It is. Da Vinci's a robot.
And when I went into the surgery room, I kind of looked over at the machine. Let me tell you, it's huge. It looks like a robot too.
It does.
It looks like a robot. Almost something from Star Wars like. But I made the decision that I didn't want radiation. I didn't want the seeds. And having looked at some of the pamphlets, I thought that was the best thing for me. I came from the school of thought, let's get it out of me now. I don't want to have to deal with this at all. You know, if it's spread, well, so be it. But let's get the core out. So that was my thinking when I made those choices. When I was presented those choices, and I presented those options, and I made that choice.
I will tell you that I find that is the most common, most common comment, and the reason why men choose the surgery as well is it's get it out of me. So I think the good thing, and maybe sometimes the challenge too, though, is that there are so many options for men with prostate cancer that it makes it a little bit more difficult and more challenging to try to help determine what it is that's the right one for you. But I think you have to look at and weigh all of that.
And I'm presently on hormone therapy, and I mentioned that in the opening. And yes, I take shots probably every 6 months. And the purpose is to, and I'm not going to explain it in the way that my urologist would explain, but basically it keeps the cancer cells that might be floating around in my system at bay. And that's the best way I can explain it. There are some complications or side effects, but so far so good. My PSA count has remained low. So.
And that's the goal. You know, when we talk about hormone therapy is often used for more advanced cancer, but also in your case, there was evidence of it in the lymph node, and it really is to help keep it from going anywhere else if there happens to be any cancer cells remaining. Because what hormone therapy does is it really is used to reduce the male hormones in the body, such as the testosterone, and it blocks it because the male hormones are really what can stimulate prostate cancer cells to grow. So essentially we want to starve them. We don't want to give them the food or what it is that they use to grow. And it is something then that can cause it to shrink, and it can maintain for, it can provide wonderful options, wonderful outcomes. You commented about the side effects, and there is with any treatment. And I think the two most common that are there no matter what, it's just in varying degrees, is that of the incontinence, the difficulty for a while or for a longer period of time of controlling the urine after surgery, even radiation therapy, and then also of the impotence that can occur. And again, that can exist with anything, with any of the types of treatment, and those are something that have to be taken into consideration. And are important. And things that need to be discussed at the time when treatment decisions are being made.
And those were discussed when I made my decision, and the urologist made the recommendation that I go on hormone therapy, and I said, okay, let's do what we need to do.
I think the other piece, the other type of treatment that we haven't really seen much benefit of in the last years, there haven't been a lot of options, is that have been chemotherapy. Chemotherapy typically isn't used in prostate cancer until other options are not working or hormone therapy has stopped working. I think the exciting part is that there has been more focus in just the last 2, 3, 4, 5 years in trying to find other treatment options. There's vaccine therapy, other types of things that really can provide additional options for men that have more advanced prostate cancer. And that's exciting news. So that there will continue to be, I think, additional options for men who need more than just maybe the surgery or the radiation therapy option.
Okay. We have about 4 minutes left, so let's talk a little bit about later stages, and I think we've probably covered some of the later stage options, so maybe briefly we can talk about that.
The later stage options really are we have. It's the hormone therapy, it is the chemotherapy. Another thing is that sometimes with more advanced disease is if the cancer has spread, it is radiation therapy often may play a role as well, especially if it's potentially gone to the bones and is causing pain. There are a lot of things that we can do to help manage the symptoms as well that may be associated with more advanced disease.
Okay. Is there anything one can do to lower your risk for prostate cancer?
It's one of those things that it's difficult to know exactly what to do to lower it because we really don't know what causes it per se. But one of the things that there has been more exploration in is that the role of diet, that it really may play a role in the development of prostate cancer. It's not a definite yet at this point, but the things that they're looking at are especially a diet where somebody has quite a bit of red meat or is low in their fruits and vegetables, that may play a role as well. But what they think is that your fats, your animal fats, especially from red meat, may increase your male hormone levels, which then may fuel the growth or feed the growth of prostate cancer cells. So also we know, just in general, that a diet should be higher in fruits and vegetables.
Sure.
That if you like your red meats, just limit them. We're not saying avoid them by any means, but also choose your leaner cuts of meat and just be very sensible about your diet. And I think that's good advice for any of us, no matter whether we're trying to impact our risk of cancer or heart disease or just overall health.
Overall health. Well, I met you by attending the support group. And and I also kind of I even brought my shirt today. It's a little wrinkled, but it's a little big for me. But nevertheless, it was the shirt that I received when I attended the first support group meeting. Maybe you can talk a little bit about the purpose of the support group and why it's important. Because, getting men together to talk about things like this is not one of the things we do well, okay? But go ahead. And you've done this for a number of years, too.
I have facilitated the prostate cancer support group now for 21 years at Bryan. And it started as the brainchild of one of the urologists. He's now retired, but he felt that there was a need for men to be able to talk about the issues, primarily the side effects, the decision making, the need to be able to talk to somebody else who has walked in those shoes. Now, I have had, for those 21 years, at least most of them, I've had another person from the hospital. Most of the time it's been a chaplain, and it's been a man, because I don't have the same worries. Now, my worries are for my husband, whereas, another man, it's personal.
Sure.
But the group, we probably regularly have 20 to 25 people. We've been up as high as 50 many times. We'll have spouses or other family members attend. But really it serves two purposes in my mind. One is that we try to provide information about prostate cancer, new treatment methods, new options that are available, managing the side effects, whether it is dealing with the effects of incontinence or dealing with the effects of impotence, or the risk for men who are on hormone therapy of making sure that their bones stay strong.
Exactly.
Because that can be an effect of that treatment. The other piece, though, is the support that gets provided for one another. It's sharing the stories. It's saying, you know what, I did deal with this, and this is what helped me. Or when I asked my doctor, this was the additional information that I got. It's really about empowering somebody. It's taking control of your own health. And we also talk about topics that are just general health related topics, so that it isn't just about the prostate cancer. It doesn't define you.
Sure.
You're still Larry.
Yeah.
Prostate cancer will, so to speak, always be on your resume, but it isn't who you are. And so it's important that at the group we also really try very hard to keep focusing on just general health from many different perspectives.
Okay. We're just about out of time. Maybe quickly you can tell folks when the support group is?
Sure. The support group meets on the second Thursday of every month. We meet at 7:30 p.m. We meet at Bryan West, which is on 16th and South Street.
Okay. Well, Ruth, thank you so much for being here with me, helping me tell my story to everyone in Lincoln and Lancaster County, and for providing information which I think is so crucial. As I said in my opening, this is for any man in your life. Be sure to take that annual checkup, because you just don't know, and you need to know, you need to be in control. Thank you for tuning in to Health Matters. I'm Larry Williams, and we'll see you next time.